Bucky IVF Innovation Hub podcast.
Hello, everyone. We welcome Dr. Karinia Khouri, specialist in obstetrics, gynecology, and infertility. She's specialist in female infertility, and we're so happy that she's joining us today on a podcast to discuss all things female fertility.
Hi, good afternoon, everyone. We're very lucky to have with us here today Dr. Ranjith Ramasamy. He's a consultant in male infertility and a consultant urologist. And we're very happy to hear with him and to discuss the issues regarding male fertility today and how to treat the issues and overcome them. So we'll be going over a lot of topics in our podcast today, and we're looking forward to having you with us.
Hey, Karinia. So let's start with some of the most common causes of infertility. What do you think are the three most common causes of female infertility?
So basically for women, the most common cause we have today is problems with ovulation, so ovulatory disorders. And most likely this is happening these days because of PCOS. So PCOS is definitely on the rise because of obesity, the obesity epidemic. And this is the number one cause of infertility we have in women today. The second most common issue that we're having is because women these days, they're wanting to have their reproductive life at a later age because of their career or because of other issues in their personal life or business life. So we're seeing a lot of women come to the clinic wanting to start getting pregnant after the age of 35. So this is very common. And as we all know, female age is a very important player in reproductive fertility. So second is the quality of the eggs and the advancing age of the woman who's looking to get pregnant. Third, we have a lot of issues, for example, in fibroids, in the issues with the uterus itself. So if we have any fibroids, any polyps, anything that is distorting the cavity or the uterus in order to get pregnant. So these are the three most common causes that we're facing today. But the most challenging one, I would say, is the issue of the female age. This is what is most challenging to IVF specialists nowadays. What about in men? What do you see as the most relevant factor that is causing male infertility these days?
Sure. So just like in the females, in men, the low sperm count happens because of three most important causes. Number one is called varicocele. These are dilated veins around the testis that can increase the temperature of the testis and affect both sperm production and testosterone production later on in life. Number two are simple correctable factors like obesity, diabetes, smoking, excessive alcohol use. I think environmental factors have a large part to play in sperm counts declining, both in men individually as well as in the society as a whole.
True.
And then finally, I think low testosterone. Even in young men, because of the sedentary lifestyle, because of obesity, I think we're seeing large increases in men with low serum testosterone. And I think low testosterone that happens in men also leads to low sperm counts.
That's very interesting because we're facing actually the same problem in women. So I've had a lot of patients ask me recently if it's true that male fertility as a whole, it's declining over the past couple of years. And I think you are seeing that with your male patients. Correct?
Yeah, no, absolutely. Yeah. I think globally there are now studies that show that sperm counts have declined from the 50s to the late 90s, from the late 90s to the early 2000s, and then all the way until like early 2020s. We don't know if it's a phenomenon of labs just changing on how we count the sperm and how we look at the quality of sperm, or do we think it's a true phenomenon of where the sperm count is actually going down? I think there's lots of factors. Number one, the environment that we live in now is very different from the environment that our parents lived in.
That's true.
Things that we are exposed to in terms of endocrine disruptors like microplastics, cell phones, radiation, secondhand exposures from pollutants in the air, water, food that we eat. I think all of these things is different now than it was 20 years ago.
Exactly.
Even when we were kids, I think this was different from what we are exposed to now. And I think these are all factors that are playing into low sperm counts.
Exactly.
What do you think about eggs? You know, I mean, you talked about maternal age and declines in egg quality and counts as women get older. but are you seeing a lot of young women now with low egg reserve and low egg counts?
Funnily enough, yes, we are. So let's say a few decades back, we had the AMH. It's a blood test that women do, which will show us our ovarian reserve and will show us on average how many eggs or what's the average number of eggs we have left for our reproductive life. And decades ago, women's AMH was more on the average to higher side. So now we're seeing an increasing number of women at a lower reproductive age, women in their early 30s, even in their late 20s, who are coming to us with a lower than average AMH. And this is due to, as you have said, it's due to the change in our lifestyle, the change in our environmental lifestyle as well. Mostly diet plays the biggest role here. Diet, obesity, lack of exercise, and as you said, the exposure to all these microplastics. So with the change of the environment recently, I mean, we're seeing a lot of women that are having very bad lifestyle. For example, they eat processed foods, diets that is very high in processed foods, unhealthy fats, basically food that's packaged in so many plastics. So we know that plastics, they have a substance called BPAs, the bisphenol A. And this substance, when we consume it on a daily basis, and when it's found in the water that we drink from plastic bottles, the food that we consume that is in plastic containers, for example, when we consume this on a daily basis and the amount of plastic that in our blood, it reaches a high level, it does impact our egg count, even our egg quality, our AMH level, and as you have said, the sperm quantity and quality as well in men. So this is really a very important factor as to why we're seeing lower AMH as well. And it's definitely on the rise.
Got it. So
Yeah.
what do you think couples should be doing, in terms of females? Like if there are three things that you would advise a female patient that's sitting in your office with infertility, with low egg count, and they're asking you, Dr. Karinia, what three changes can I make when I go home to try and see if I can improve my count and my quality of eggs?
So first of all, I would advise her to rethink her diet. So most women we see now, as we've spoken about, they consume a very high amount of processed foods. And most women who come to us, they ask, okay, doctor, what's the best diet that you can be on to prepare yourself for fertility and to prepare yourself for a pregnancy? There is no really one best diet, but if we look at the literature and if we look at the studies, a lot of studies mentioned that the Mediterranean diet is the healthiest that we can have. So the Mediterranean diet, basically, it's a diet that's rich in fruits, fresh vegetables, rich in seafood and white meat like white chicken, white fish, not a lot of red meat. So this is the problem that we see with women nowadays, the ones that are consuming a lot of red meats, a lot of processed meats. This will also affect their egg quality and quantity. So I would advise them to cut down on that and advise them also to cut down on high glycemic foods like white sugars, white rice, white pasta. So instead of those kind of carbohydrates, focus more on the rich carbohydrates that is basically low glycemic index. So like, for example, oatmeal, brown rice, brown flour, brown breads. This will lower your risk of diabetes and it will lower your glucose levels overall. And another thing, so this is one, the diet. Another thing I would really advise them to focus on is sleep, because we see a lot of women nowadays, they're stressed, men too, I
Right.
can
Yeah.
imagine.
Yeah.
Yeah. So the high amount of stress and the cortisol levels in their blood, it's also going to negatively impact their menstrual cycles and their fertility as well. So they really need to cut down on stress. And I mean, it's not about cutting down the amount of work, but finding something that will de-stress, like yoga, meditation, something like that, at least to improve the balance in your lifestyle. Third thing that I would highly stress to do before starting your fertility journey is exercise and weight loss. So we need to really make sure that the woman has a good BMI before starting. So I'm sure you see this in men as well.
Right. No, absolutely.
Yeah.
I think the three things that I would tell a guy anytime he says, Doc, what can I do
Yeah.
to either maintain my fertility or try and improve my fertility is number one, smoking.
Yeah,
I would
correct.
absolutely cut it. People think, especially now with vaping and IQOS, the amount of nicotine actually in vapes and electronic cigarettes and IQOS is a lot more than just regular cigarettes.
That's true.
And people often think that vaping and IQOS is somehow safer for sperm than just regular cigarettes. It's so not true. So really to cut back on any form of smoking that they're doing, cut it down to zero if you truly want to both improve your sperm count and importantly your sperm quality.
Correct.
And then the other two things are, I think, fairly similar to what you mentioned in females: weight loss. Somehow achieve that weight loss. Whatever you can do: intermittent fasting, keto diet, even drugs like GLP-1 agonists with Ozempic, Mounjaro. All of those things will help weight loss. And weight loss has independently shown to improve sperm counts. In fact, double sperm counts by about 3 to 6 months.
Oh, wow.
And then
Okay.
finally, I think physical activity and getting
Yes.
good sleep. Even if they can get 6 to 8 hours of good quality sleep, I think it's much better than 8 to 10 hours of interrupted sleep, for example.
Exactly.
So I think all of those are really, really important.
Do you recommend? Oh, sorry. Yeah.
No, I was going to say, I mean, like there's a lot of buzz and talk about supplements these days.
Yeah, that's what I was going to ask you.
Yeah,
So do you recommend your patients to go on a certain supplement before starting IVF or before planning for pregnancy or just diet?
So the data on supplements is very mixed. Some
Yeah.
studies have shown that supplements actually improve sperm count and quality. Some studies have not. But I can tell you at least the 5 most important supplements that are that have been shown with some amount of evidence to try and improve sperm count and quality are vitamin C, vitamin E, zinc, selenium, and CoQ10.
Okay.
So as long as that has any supplement that you're taking has a combination of those 5, I think that's very good. But what do you suggest in men, in
So
females?
for women, really, it differs. So we have, as you said, I mean, we don't really have any conclusive studies on whether a certain supplement will really benefit, will really increase your risk of having your chance of having a pregnancy or a live birth. And the supplement that's needed, it really differs from patient to patient. For example, if I have a patient who comes to me with PCOS or polycystic ovarian syndrome, other than the lifestyle factors, the weight loss and the diet, sometimes we advise them to take inositol or myoinositol. So this is a supplement that is basically like an insulin sensitizer. So it will improve the insulin resistance in a woman's body who has PCOS. And also additionally, it may help improve the ovulation. So it may regulate her ovulation or get her ovulation back in order so that she will have regular cycles and maybe be able to conceive a bit better. So inositol, definitely we can supplement these to women with PCOS. But again, there are no studies that are conclusive that say that it will get you fertile. No.
Right.
But whether it does not harm, it may play a benefit. Yes. For example, for patients who have endometriosis, so the endometriotic implants on ovaries, on the uterus, there are some studies that showed that vitamin D might have a benefit, that omega fatty acids, omega-3 might have a benefit as well. But whether these are conclusive, not really. Then again, it really goes back to each individual patient and each individual case. And for the subgroup of women that come in with, for example, high stress or high oxidative stress. So usually for these women, we give supplements like antioxidants. For example, coenzyme Q10, glutathione. These also, they don't have any shown, 100% shown benefits, but it does slightly improve the egg quality, especially if a woman wants to go for egg freezing.
Got it.
So these are some of the supplements that we give. Definitely, it's not all for one. So
Got it.
it's not one same supplement for all patients, but we have to individualize the approach.
Got it.
Yeah.
What do you even before we get into the discussion of IVF and IUI and assisted reproduction, a lot of couples want to try and optimize their natural fertility, natural conception, all the way from, females who use ovulation calculators, females or couples who say we have sex every day, twice a day, 3 times a day during the time of ovulation. What is right? How often should they be having sex? What do you suggest about ovulation calculators? And based on female cycles, how do you recommend women use their ovulation calculators?
So I would only recommend the ovulation calculator if a woman is having very regular menstrual cycles. So if she knows that she's having her cycles every 28, every 30 days, then yes, use an ovulation calendar. And when you know that, for example, if your ovulation is today, then I would recommend having intercourse at least 5 days before until 1 day after your ovulation. If you can every day, even that would be beneficial. Before, studies used to say that you can try every other day, every 3 days, but actually the more sperm you get in there, honestly, the better it is.
Right.
So if you can have it every day around intercourse, around ovulation, then definitely it will really increase your chances of getting pregnant. If the woman is not having regular ovulation, if she's unsure, then I definitely don't recommend just doing calendar tracking. Come to your doctor, do a scan to check when you're ovulating. We can know based on your scans, based on your blood tests, and then we'll treat accordingly. We'll let you know accordingly.
Got it. At least
What
on the
about-
male side, I think ovulation calculator actually causes a lot of stress.
It does.
Men tell me that,
Yes.
doc, this on-demand sex is very difficult for us.
Exactly.
The females are stressed. We need to be having sex tonight. Please come home because I ovulated, the ovulation calculator is showing. So I don't know if the amount of stress that the ovulation calculator causes is actually beneficial for fertilization to happen, or it is actually harmful. I don't know. We cannot do proper studies on that. But I often hear, couples tell me the amount of stress. And I think you mentioned a very important point about having sex before the ovulation happens.
Yes.
Because once the ovulation calculator shows that the female has ovulated, it's actually too late. And so I think it is important for couples to know that they should actually be having sex at least 2 or 3 days before, and not either during or after, which the chances of natural conception actually goes down after ovulation a lot. And so I think there's a huge misconception that you need to be having sex on the day of ovulation. I think you mentioned it rightly. It's best to have it 2 to 3 days before, and even if it is 2 to 3 days before, every day before the ovulation happens. So really very, very good point. What do you think about fixing factors? So this IVF now, and IVF can obviously overcome a lot of diseases like endometriosis, tubal diseases, and so on. What do you think about trying to go and correct some of the factors in female fertility? Do you think it's worth pursuing that route? Which couples would you recommend pursuing fixing correctable factors versus those that you would say you need to undergo IVF because this is the best option?
So it really depends on the cause. I mean, for example, if you have a woman that comes with uterine factor, if she has a fibroid that is blocking the cavity, preventing an embryo from sticking inside the cavity, definitely she will have to go for a surgical fixing of that. So I would definitely not recommend IVF immediately. She'd have to surgically correct that, get the uterus back in shape, and then after a certain period of time, she can go back to trying naturally. If a woman comes to me with blocked tubes, for example, it really depends on the situation of the tube. So if there is so many adhesions, if the tubes are damaged beyond repair, then for sure I would not tell the couple to waste their time and go for multiple surgeries and fixing those tubes. Just go straight for IVF. If the tube has a small blockage that could be fixed surgically, yes, she can try for that for sure. So it really depends on each couple and what the diagnosis is. And the same applies for males. So for example, we've had a lot of couples, male couples who come in, they've had a vasectomy previously, and now they're in a new marriage or a new relationship. And they always come to me asking, should I go for repair of the vas deferens, repair of the vasectomy, or should I just go for a testicular biopsy or IVF? What would you recommend these patients?
So in those patients, I think the easiest answer is female age and female factors, right? So if the woman is young, she has regular cycles and her AMH level is good, and she has no correctable causes of female factor infertility, I think giving it a chance with vasectomy reversal is totally reasonable. Regardless of the number of years. In the past, it used to be after 10 years since your vasectomy, then your chances will go down. Honestly, I haven't found that in my own experience at all. I have done vasectomy reversals 25 years out, and they still seem to be successful. And some people who've done vasectomy reversals 2 years out and doesn't seem to be successful. So I truly think it depends on the female. If the partner is young, she has regular periods and no issues with fertility, I think giving vasectomy reversal a chance is a good idea, because during the vasectomy reversal, you can actually take some sperm and freeze it. So you don't have to undergo an additional procedure in case the vasectomy reversal does not work, to have IVF later on with that sperm that's frozen at the time of the vasectomy reversal.
Okay, that's a really good point. And what about, so we see this a lot, for example, women who come to us, female age plays a big factor, as you said. What about male age? Do you feel that the age of male patients also plays a role in IVF?
Sure. No, absolutely. I think the male age has been ignored for the most part with fertility. Finally, because in the past, I don't think older men were trying to have kids. But now I think the average age of a dad has definitely increased. Up to 45 is the average age now, and older men are continuing to father children. And lots of Hollywood stars have gone on to have kids much later on in their life. The best advice that I can give is that men will probably continue to produce sperm throughout their whole life, but the quality will decline. I always describe it like a factory. When you're 12 years old, 13 years old, the factory is new, the parts are new, and so any mistakes that people make in the sperm, they'll go back and correct it. But as we get older, I think the factory parts get older, and we can't fix all of the defects. So we'll still keep making sperm, but it'll come out with a lot of damage. And I think that's where we see increased risk of genetic anomalies. Not so clear cut as in females, that happens around 37, 38 years old. There's a label called advanced maternal age. In men, I think the number of mutations in the sperm sort of continue to increase after the age 40. But there's really no cut point or a threshold beyond which, mutations exponentially increase. But just men should know, as you get older, the quality of sperm will decline. And you should just remember that and watch out for it.
When we compare, men to women, men are definitely luckier, because The age
don't
of
know about
cutoff
that.
is the age of cutoff is for sure better. For women, unfortunately, as you said, advanced maternal age, we're considering it at the age of 37, 38. So unfortunately, this is the sad truth. Women who are even above the age of 35 notice that it's getting much more difficult to get pregnant. And this is why we really highly encourage women who are single around that age. By the age of 35, if you're single, you're not getting into a relationship anytime soon, I really strongly advise them to go for egg freezing, because they will notice. I mean, we know from the couples that come to us, women above that age, they have a less chance of success after doing one IVF cycle. So women at the age of 40, for example, have only maybe a 20% chance, or even a little bit less. So it really depends on the female age.
Got it. So
Yeah.
talk a little bit about social egg freezing. It's become fashionable in certain ways. In some ways, medical necessity, where young females, we talked about premature ovarian failure and
Correct.
AMH levels declining. So I think those would be medically necessary. But in a 30-year-old female that has a normal AMH level, let's say 5 or more, and she's not planning to get married or have children in the next 5 years, you would recommend egg freezing. What are some of the risks, and how would you counsel that single female?
Definitely. So I'll start off by saying that egg freezing, it has two major reasons for doing it. So the first, as you mentioned, is medically, whether, for example, if she's undergoing chemotherapy, anything for any newly diagnosed cancer, definitely that will damage the ovarian reserve that she has. So definitely she'll have to freeze her eggs before that. And the second is what we call social egg freezing. So social egg freezing, as we know, women are born with a certain number of eggs. By the time you reach your menarche, by the time you get puberty, these eggs counts have gone down. And each month and month, they will decrease and decrease until they reach only a couple of thousand by the time you're at menopause. And that's when your reproductive age is done with.
Got it.
So if women reach the age of 30, for example, and you're not yet in a relationship, not yet knowing whether you're going to get pregnant soon, I will advise you to at least get an AMH blood test done to check your egg count, get an ultrasound done to see where you're standing, if your egg reserve is good or not. If you find out that you have a low AMH, and by low AMH, this really depends. So severely low AMH will be below 0.5, a low AMH, let's say below 0.9. So it depends. Do the AMH blood test, get an ultrasound to check how many follicles you have, what's your egg count, and then have a discussion with your doctor, have a consultation, and see whether you're a candidate for doing egg freezing at that age or not. If at the age of 30 you have a good AMH, you have a good egg count, then you can wait another, let's say, 4 to 5 years. But by the age of 35, if you don't have a partner, I strongly advise you to go for egg freezing, because you're gonna notice how difficult it is to get pregnant after that age.
Got it. Thankfully, in men, it's not.
Yeah.
It doesn't happen that way. But I think you touched upon a very important topic, which is fertility preservation for medical reasons like cancers. The one thing that has happened worldwide, we talked a lot about environmental exposures and so on affecting fertility. I think it's also definitely affecting cancer rates.
Yeah.
So interestingly, cancer rates have actually remained stable throughout the world for the last 10 years, except in the adolescent and young adult population. This is fascinating. We actually don't know why this is the case. But young people have been increased diagnosis of cancers, and incidence of cancer has gone up in this young population. In the older population, it has remained stable. In the younger population, it has increased. And I think we have to have the conversation about fertility preservation in this population a lot more, because once they do get treated for their cancer with either chemotherapy or radiation, the chance of both egg counts and sperm counts declining to almost nil to zero is actually very high. And I think oncologists, patients need to be aware that at the time of diagnosis, not after treatment, but really at the time of diagnosis is when the concept of fertility preservation needs to get discussed. In females, it's a little bit more complex. In men, it's a little bit more straightforward as long as they've gone through puberty. Then trying to freeze the sperm is actually very good. Patients always ask me, Doc, how long is the sperm good for? Studies have shown it's actually 85% successful up to 15 years after it's frozen. So as long as you're planning to do something in your life with your reproductive age, I think it's a very good idea to both have the conversation about fertility preservation and also seek out places that do fertility preservation and freeze your sperm and or your eggs at the time of diagnosis. Not at treatment, not after treatment, not let's do 1 or 2 cycles, let's see how the cancer progresses, then let's talk about fertility preservation, but really at the time of diagnosis, which should happen. But I'm happy we're having the discussion.
Yeah, unfortunately, it doesn't happen with all doctors here. So we've had quite a few cases of women with newly diagnosed breast cancer who already underwent chemotherapy, who already did the mastectomy and have done surgery. and then come to us and ask about, okay, doctor, what do I do now? And unfortunately, at sometimes it's too late. So this is why it's really important to raise awareness and let everyone know that if you, God forbid, have a cancer diagnosis, are due to start chemo, it's very important to see your reproductive endocrinologist, your gynecologist, urologist, and have that discussion and freeze your eggs or sperm before. So for sperm, for males, it's very easy. You just give the ejaculate sample and that's it.
Right.
For women, it's not that easy. It's a invasive procedure. So when we do egg freezing, it's basically a 2-week process where the woman has to take some injections, fertility hormones to stimulate the growth of the eggs, and then do a procedure where we take out the eggs through vaginal aspiration, through vaginal surgery. So at sometimes we don't have enough time if she's diagnosed with the cancer. She tells me that, okay, I don't have 2 weeks. So at that time, we might have to just put her on some suppressive treatment and hope that the ovaries will be suppressed until once she's done chemo. But if we have time, so if she knows that she's diagnosed with a certain cancer and we have time, definitely go to your doctor, have the 2-week treatment, get your eggs frozen, and then at least you'll have your peace of mind. You can take your chemo and then you'll have your eggs stored as a backup. So this is an important point to know.
All right. I think that was a fantastic podcast to all of our viewers. Thank you very much for joining us. And any questions you have about male or female fertility, please don't hesitate to reach us out at the Jumeirah American Clinic. Thank you.
Okay. So we were very happy to discuss the important points that we're facing in male infertility and female infertility. And we're happy to have any questions from the audience. If you have any questions, please reach out at Jumeirah American Clinic with Dr. Ranjith and with myself, Dr. Karinia Khouri. We'll be more than happy to help.
Thank you.